Good morning, everybody, or good afternoon. Thank you so much for joining me today. I have my very good friend, Pam Vanderbilt, with us today. Hey, Pam.
Good morning.
Good morning. We are going to be talking today about the musculoskeletal system. But before we do that, normally I tell you the type of day that it is. And in full disclosure, I'm on site in Charlotte, North Carolina today at a brilliant conference, the National Society of Healthcare Business Consultants. Amazing conference, having a great time. But I have to be honest, I just came back from a retreat with Pam. It was unbelievable, friends. I got to tell you, it was like nothing I have ever experienced in all of my years of conferencing and boot camps and sessions and meetings and annuals. And it was so unique. The conference was, I'm sure you've all seen it on LinkedIn. It was in San Diego, California, hosted by Advanced Coding Services. Beth Schleiper, amazing. Sonal Patel was there. Betty Hovey was there. Like I said, Pam and I were there. There were so many other people there. Lady Martinez. It was a fantastic, phenomenal event. And I only say this to encourage you all to join us in September in New York for another retreat, or in Prescott, Arizona in October for another retreat, because the education, the fellowship we had together, the knowledge that we gained was priceless. I don't know how you felt about it, Pam.
Oh my gosh, you hit it completely on the head. It is not a conference. It is a retreat. And so although we are sharing education, sharing knowledge, getting education in CEUs, it's really an opportunity to build relationships and get to know people. And it's not a speaker on a podium style at all. It's very conversational, even during the education sessions. So people are free to ask their questions. And there were several of us there that absolutely have a passion for evaluation and management services, and in spite of the fact that we stick at those guidelines, we know those guidelines like the back of our hand.
Mm-hmm.
We were asking questions and hey, how do we handle this, and what do you think about that? And it's the atmosphere is just so different from a conference because you have the opportunity to do those things. And then on top of that, when we're not learning, we're still hanging out together, playing games, getting to know each other on a more personal level. So we're there with friends. We're not just there with colleagues, and it just makes it a very different engagement than anything else.
Absolutely.
And the view is fabulous.
And the view was fabulous. Yes, we were right on the Pacific Ocean. It was still, like, I'm still riding the high. I don't know about you, but it was incredible. Yep. And it was even nice because even at dinner time, if you had a thought, oh, wait, Pam, you had mentioned something about modifier 25, and we were able to discuss it over dinner, like, because we speak the same language and we think the same way. And it was just a wonderful experience. So I'm going to leave it at that. If you want more information, you need to sign up and meet us in New York City, or not in the city. We're going to be in the Hudson Valley. Sign up and meet us in New York in September. It will also be my birthday weekend. So if anybody wants to come hang out for my birthday and education and fellowship, I'll see you there.
Absolutely.
So today we're going to talk a little bit about the musculoskeletal chapter of the ICD-10 guidelines. And I love this one, I'll be honest with you, because I think we were talking offline a little bit. Chapter 13 really brings us into the musculoskeletal and connective tissue. And I have a connective tissue disorder, so it's true to my heart. And but it also kind of overlaps a little bit into our chapter 19, or Yeah, 18. 19. So I think it's really important that we talk about the differences between the two chapters. The first thing though that comes to mind, and I think we talked about this during the retreat as well, was laterality. It drives me nuts when I see unspecified laterality.
Agreed, 100%. And that is one of my biggest pet peeves, partially because when we were making the move into ICD-10, I was in charge of the revenue cycle for a large orthopedic practice. And when I started looking at notes to start educating the providers, I realized just how many of our notes did not specify laterality. And I'm like, dudes, I can't read your mind, and neither can anybody else. And if you don't know your left from your right, we might have a problem. So
I was saying to them, like, you had it in your hand, right?
Yes,
you are
exactly.
holding the left leg. At what point did you forget that was
yeah, yeah. Lefty loosey.
Right? Here's my thought. My thought process goes back to when we did the GEMS mapping from ICD-9 to ICD-10. And ICD-9 had all of those unspecified and didn't have the laterality built the way that ICD-10 does. So Doc said, just build me a cheat sheet. I hate that word. A cheat sheet that takes me from my 9 codes that I know to the 10 codes. Well, if you have unspecified, the equal would be unspecified. But we've been doing the ICD-10 for 8 years now. What's
Agreed.
the problem?
Yeah. Well, and I think that the GEMS mapping still comes into play because even with our smart search tools, we'll see that if they type in, for example, right knee osteoarthritis, it will pull up a description that says right knee, but the code that's associated with it is still the unspecified laterality code.
Yeah.
And so a part of that is not using the smart search tools correctly, because there is a hyperlink on those that you click on and then you get to the more specified code, right? But they stop at the description. And to the provider's defense on this, they see the description says right. They are not coders, so they don't necessarily equate that the code is not correct for the right knee. And so, there's something in the background that we have to do to fix that. My opinion is we take all the GEMS mapping out of it and we start actually living in the ICD-10 world before we get to ICD-11.
Couldn't agree with you more. Very well said. Very well said. And I struggle with that. I also think one of the other culprits is for maybe some of the smaller practices that they're still using encounter forms. And look, there's only so much you can squeeze on one piece of paper. So everything ends up being that unspecified. So in this day and age, with electronic medical records and in the practice management softwares that are interfaced and integrated, why do we still need those silly super bills?
Yes, I agree. One of the first things I recommend to new practices when I come in is, if they're using encounter forms, is stop wasting the paper.
Agreed.
You're killing trees, and you're creating additional work, which means additional expenses, because somebody's got to take it off the paper and get it entered into the system.
Exactly. And you tie people's hands sometimes, because going into the electronic medical record, we really get to see that laterality reported. We really get to see, maybe there's more going on that you documented, that it expands beyond the little box that you have that limitation on the super bill.
Absolutely.
Yeah.
So well, and I love the go ahead. I'm sorry.
No, go ahead.
Oh, I was just going to say, I love chapter 13. And as we were talking about offline, when we start talking musculoskeletal, we think orthopedics. And so orthopedics is not just tied to chapter 13. There are other chapters in ICD-10 that we deal with a lot, including the neuro chapters.
Mhm.
So, if you're looking at your job responsibilities, remember that you may need to be looking at more than one part of the guidelines in ICD-10 to make sure that you are covered, because your disease processes may not all live in one chapter. And
Right.
definitely that's true for orthopedics.
Think about pain. Pain goes directly to the neuro chapter, where we have specific guidance on how to report if someone's coming in for pain management, usually related to something in the musculoskeletal system. So something in your back or something in your shoulder, hip, elbow, knee, right? That those are the usual culprits as I start to get older and get a daily reminder every day. But the musculoskeletal system is like, come on, lady, give us a break.
Exactly.
Now, we also talked a little bit about the difference between the traumatic fracture and the pathological fracture. And for new coders out there, I can see how it could be confusing and not clear when we're selecting a code based on a pathological fracture or a traumatic fracture. What has been your experience with that, Pam?
Well, it is very confusing, particularly because a lot of times our providers don't distinguish between the two. In their head, a fracture is a fracture, and they don't really care. But we do have differences. If a fracture happens as a result of an acute traumatic injury, we're going to be in the oh shoot chapter, and our codes are going to start with an S, right?
Right.
But if we've got underlying disease processes in place, that the bone is not normal, healthy bone, and therefore that patient may have had a fall, or maybe the disease process is so significant that it doesn't even take a fall. They just, as we always do, bump into something, and I look at it and go, where'd I get that bruise? That's
Yeah.
not that would actually break their bone. And so those belong in our M chapter. Even though it's a fracture, it is not an acute traumatic fracture that belongs in the oh shoot. It is because of the underlying disease process. And we have multiple types of pathologic fractures. We have a whole section of codes specifically titled pathologic fractures. So we would be in like the M84s. But we also have a big one out there, and that's osteoporosis.
Yeah.
And so if the fracture is in a patient who has osteoporosis, we're going to code that fracture regardless of how it happened with the codes for the osteoporotic fractures.
Well, osteoporosis, if you really think about it logically, it's the bones becoming more ossified, and that means it's starting to look more like a sponge. And you've seen in a sponge, right? Some of the holes in the sponge are very small, but some of the holes in a sponge are very big. And imagine that if all of the holes that are within the bone that create that bone structure, they become larger, more brittle, then the strength or the integrity of that bone inside is more brittle, like, again, like a sponge bubble. And something very simple, like bumping into something, could fracture those little the little bubbles there, pop the bubbles per se. And let me tell you, anything bone related is extremely painful. So even though the bone has ossified into some larger bubbles per se, the pain from breaking that is no different than any other bone pain that someone might have. So now if you think about that, right, you've got the sponge within the bone, it breaks inside, and it doesn't take a whole lot to make that happen. Where a healthy person whose bones are not ossified or not spongy like that, they have that structure there. They've got the strength in the bone, and it really takes something massive to break it. So I think once you start to visualize what pathological is versus traumatic, it makes more sense to me, at least.
Absolutely. And I think that, we also have to pay attention to other triggers that we might see when we're looking at documentation, that may give us a clue. For example, does the patient have cancer? Are they being treated for cancer? And if they are, and they have a fracture, and we don't see a correlation in the documentation, we may have to go back and query, is this a pathologic fracture in neoplastic disease, or is this an oh shoot fracture that healthy bone would have broken if we did this?
I had a friend of mine who had cancer of the bone, and it didn't take very much at all for him to have fractures. So a tripping over a stump caused a
Yep.
fracture, where normally that would have never happened, but the cancer was basically disintegrating the bones or eating the bones and making them so brittle and so susceptible to even the minorest of injuries. And again, that has nothing to do with that healthy, strong bone that really needs something massive, an accident, in order to make it break.
Right.
So you have a good way of looking at it, whether it's a normal musculoskeletal pathological disease like an osteoporosis, or maybe it is cancer related. That's either way you look at it. It's a compromise of the bone that causes that bone to fracture so easily, versus a big accident out there, like accidentally driving a jet ski into anyway, we won't talk about that.
Right. Doing that. That's an oh shoot code. We will use our S code.
I love that correlation. Oh shoot, and the S codes.
Yep. So, talking about that relationship between acute traumatic versus pathologic fractures, we also see in orthopedics other conditions besides fractures, that similar thought process applies to. We did a lot of sports medicine in the practice that I was in, and these athletes would get a rotator cuff tear, or the football players were always doing something to their knees. And if we have that traumatic injury that we have repaired, and then it recurs, it happens again, part of the reason it happens again is because that is no longer a healthy, normal structure. It has been degraded and weakened by the original oh shoot injury. And so we have guidelines that tell us, even if it happened acutely, for example, they're in the middle of a football game or a baseball game, right? Mm-hmm. That there is disease process now, and that recurrent injury no longer gets coded in our oh shoot chapter. It gets coded in our M chapter, because we're not dealing with healthy anatomy at that point.
Well, this is sort of off topic, but my husband had a knee replacement a few years ago because he had worn out the meniscus between his knee and was bone on bone. And it was from years of kickstarting his motorcycle. So he was a dirt bike rider from the time he could pick up the dirt bike to right. And the dirt bikes were all kickstart. Now they have electric starts. How rude. But they were all kickstarts. And he was an avid rider. So by the time he hit 50, he had no meniscus left. There was nothing there. It had all been worn down. He'd had multiple arthroscopic surgeries to either cut out some meniscus or repair some meniscus. And then, at some point it was like, it's all gone. And it became more musculoskeletal, where initially, like you said, maybe in his 20s, it was a traumatic tear of the meniscus. Now in his 50s, there is no meniscus because it's worn out, it's gone. And it was definitely from a pathological reason at this point to have that done. So it could be many different things, or it could be over the course of a long period of time that degeneration happens, or that breakdown happens. And because it causes a more of a pathological injury. So as we start looking at our older population coming in, that history component, even that social history component, is really important. Were you a football player? Were you a basketball player? Were you an athlete? Were you a rodeo bull rider that had multiple fractures? And all of that really becomes more pertinent as we get older.
Exactly. And something else to keep in mind is when we're in those situations. So maybe we had that fracture as a youth that would have been coded in the oh shoot chapter, and now we've got pathologic disease as a result of it, right? Mm-hmm. When we're billing that pathologic disease, we should also be coding our original oh shoot injury with the 7th character of S as a secondary diagnosis code, because that shows that this is an after effect, a late effect of that original injury. And that is what our sequela codes are intended to be used for.
It paints the picture, as our friend Sonal says, yes. Right?
Exactly.
I couldn't have explained it better myself. When we get to chapter 19, I always have a fun time describing those encounter codes, but it's so true that sequela codes are used to report a new problem that's related to an old problem or developed from an old problem. So it paints that picture of how we got here today. And I'll tell you, from a doctor's perspective, sometimes just that knowledge minimizes the amount of diagnostic investigation that a doctor needs to do to get to the root of your problem. So it was easy for my husband's doctor to understand why the meniscus was non-existent because of the history. But had he not given that history, there would have been multiple MRIs or multiple scopes to go in and take a look at, rather than relying on that history that was so important and it related to the current injury.
Absolutely, which takes us back to our E&M. Just because we don't bean count history anymore, it is absolutely the opening paragraphs of the story we're telling about the problem.
Yeah.
And it is incredibly important that we still capture that information so that we know the beginning of the story.
Was it, I think that is so super important, because I know providers, and especially orthopedic doctors, low back pain. Well, is it a sharp pain that just came on, or is it a dull pain that has gotten worse over the course of a year? Well, the diagnostics are so different based on just that reporting, the etiology of the present condition. That information it routes the rest of the visit. It routes the E&M visit. Something sharp is very acute. You need to do something about it now, because I'm not walking out of this office feeling like this. Where something dull or something that's been growing, yeah, I know I'm going to have to do maybe ibuprofen or nonsteroidal anti-inflammatory. I'm not going to get that resolution maybe today in the office. So very, very different.
Absolutely, it is. It is. So, when we talk about the orthopedic chapter, we touched on earlier laterality and how dare you not know if it was the left or the right. But we actually have guidelines about how to report our services when there is a code for bilateral. Mm-hmm. And it's in the chapter specific, it's actually in our general coding instructions under number 13. And it tells us if the problem exists bilaterally and we have a bilateral code, we report that bilateral code even if our treatment today is only on one side. We don't stop and use a unilateral code until we have corrected the problem on one side, and then it only exists unilaterally.
Right.
I see a lot of times I'll get right knee and left knee osteoarthritis. And I'm like, wait a minute, we have a bilateral code for that. Right. But maybe there goes supplementation on the left knee today. They'll report the unilateral code, but I can see a problem list that the patient has a bilateral OA. And so we need to be aware of that so we can share the writers and coders and auditors that we do have instructions, and orthopedics is definitely one of those where we see bilateral codes, that we have instructions that we will always report bilateral until it doesn't exist bilaterally anymore.
Agreed. And I'm glad that you mentioned that, because that's one of those other little golden nuggets within the guidelines that answers that question and provides us with correct coding.
Yes.
I think the last thing we can segue into is that beautiful general guideline number 14, where it says, if you get that unspecified laterality, that as a coder, and when I saw this, I completely just had a little like happy dance. It says that a coder can look within the medical record at another clinician who has documented the laterality and use that to assign the most specific code for that injury or that pathological situation, and it gives us a little bit of power as coders, to make that decision and use that either bilateral or unilateral specific code.
Yes, absolutely. And so that ability to use other providers' documentation or look back, for example, patients sometimes coming in post-operatively, when we do total joints, and then we follow up annually to make sure that that joint is still stable, correct? And so if they're coming in for a 1-year follow-up or 2-year follow-up, we might only see in the documentation that they're following up for a total joint replacement, but we can go back and look at which joint did we replace and get the most specified laterality code for it.
Right. It empowers the coder in allowing us to assume, which is something that we've been drilled into. We are not allowed to assume. We're not clinical. But remember that laterality doesn't change the clinical diagnosis, right?
Right.
So osteoarthritis, osteoporosis, pathological fractures, traumatic fractures, we don't change that diagnosis by adding the laterality to it. So as it is something that is allowed or accepted by a coder to make that specification of left or right or bilateral, because it doesn't change the diagnosis itself. It only makes it specific.
Absolutely. And I know every ICD-10 book is a little bit different. The one that we use has little tips in it. And there's actually a place that it has a little tip that if we can't find the laterality within the medical record, query the provider.
Yes.
And I like that we're seeing that language hit our ICD-10 books. It's okay to have that conversation. It's important that we're having those conversations with our providers, because first of all, if we keep querying them, they're going to finally figure out, why are you bugging me so much? And that opens that opportunity that we can educate them, so therefore we don't have to ask the questions anymore. So right. If you do this, then I don't have to do this.
And I say it all the time. And I tell providers, listen, when you're doing, when we're doing education, when we're doing monitoring and auditing for our compliance programs, in the beginning, if you've never had this done in your practice before, there's going to be a lot of back and forth. You're going to have your coders, your billers coming back to you, and even annually as things change. You should expect your coders and billers to be coming back to you with the query, because that query is telling you that maybe guidance has changed or you're missing something that supports. They're really working for you and with you to make sure that you've maximized all that you possibly can document, not just from a reimbursement perspective, but maybe from a legal perspective or even a continuity of care. I'm sure that if you referred a patient out to have a knee replacement, that the orthopedic doctor would appreciate knowing which knee it is that you're asking, information on to get replaced.
Yeah, exactly. Exactly. It's always helpful. And sometimes it's amazing how little we see documented in the notes and went to that continuity of care.
Mm-hmm.
You know, primary care is referring a patient to any specialist, and they've got sketchy documentation. The specialist is not going to know why the patient's being referred. But unfortunately, the patient may not know either, because the documentation's so sketchy, the patient can't even determine what they're being referred for.
Exactly. We need to remember that. We really need to remember that, and make sure that we are doing the best that we can for our patients. And then as coders, we're doing the best that we can for our providers.
Absolutely.
Can you believe our time is up, Pam?
Oh my gosh, already?
Yes. I can't believe that. Yes. I want to remind everyone again that we have the retreat coming up in September. It's Advanced Coding Services, Beth Schleeper. If you can, the information will be all over the place. You'll be able to see it on LinkedIn and on Facebook. And I really, really encourage you, if there's one education, and let me tell you, the conference is in September. So I know that we'll be talking about a lot of change. We will be talking about the proposal that comes out. We'll be talking about ICD-10 guidelines that come out. So if you really have maybe one education to focus on in the future, I would think about the retreat. It's a unique way of receiving information. It's a relaxed environment. You can't beat the price for the retreat, and the networking, the fellowship that we have together is just outstanding. So keep your eyes open. And in the meantime, if you have any billing coding needs, please make sure you reach out to my good friend Pam Vanderbilt there, and she can help you. She has a consulting firm and a billing company, and she can take care of all of your needs there. So her information's passing across the bottom there. Make sure you reach out to her. If you're not connected on LinkedIn, make sure you're connected. You connect with Pam on LinkedIn. Absolutely important. Pam, thanks again for joining us today.
Thank you, Christine. Enjoy the rest of your conference there.
I will.
We'll see everybody soon.
All right. See you soon. Thanks so much.
Thanks for watching.